Hi, welcome to the online classroom portion for the Regional Anesthesia Workshop, TSA 2022. My name is Dawn Yan, and I'm an anesthesiologist in private practice in the Dallas Metroplex. And me, along with Dr. Kay Water of MD Anderson, are here to present thoracic wall blocks. We have nothing to disclose. We will go over the relevant anatomy and corresponding innervation for these thoracic wall blocks and summarize their indications, review the ultrasound technique, go over the local anesthetics used, and overall important concepts for each of these blocks. As these fascial plane blocks are being discovered and evolving, there came a need for standardization of the nomenclature that's being used. So there was a first international consensus study comprised of 60 international experts who collaborated on coming up with the acceptable nomenclature for these blocks. And a change that you'll see over time is that what was initially called the PEX-1 block is now being more accurately described as an interpectoral plane block, and the PEX-2 block is now called the pectoserratus plane block. These thoracic plane blocks are a new and rapidly changing area of regional anesthesia. These techniques offer excellent analgesia, have less side effects, and a better safety profile than some of the traditional thoracic anesthesia techniques. Some of the ones we'll be discussing today are the superficial parasternal plane block, the interpectoral plane and pectoserratus block, which again was formerly known as the PEX-1 and 2, the serratus anterior plane block, and on the back we have the erector spinae block, as well as a paravertebral block. But as you can see, there are many other fascial plane blocks out there that have been described in the literature. We'll start by discussing the paravertebral block. Paravertebral blocks are a great alternative to the traditional thoracic epidural. It gives you a unilateral block of the dorsal and ventral rami of the spinal nerves, as well as the sympathetic chain. Indications for its use are for breast and thoracic surgeries, upper abdominal cases, open nephrectomies, as well as treating pain from rib fractures, cancer, and postherpetic neuralgia. There are many ways of doing a paravertebral block. The traditional loss of resistance technique has about a 10% failure rate. That's improved with the addition of a nerve stimulator, and the newer ultrasound guided techniques are very safe and effective. The paravertebral space is a wedge-shaped potential space that sits behind the transverse processes. It extends from T1 to T12 along both sides of the vertebral column. Your goal with the block needle is to pierce the superior costal transverse ligament, which is what gives you that pop sensation when you do it the traditional loss of resistance technique. Upon injection of local anesthetic, it will spread cephalad and caudad, and on ultrasound, you should be able to visualize the downward displacement of the pleura, which will be a hyperechoic line. 20 cc's of local anesthetic will spread about 4 to 5 dermatomal levels, cephalad and caudad, and if you want greater dermatomal spread, you can do a 2-level injection. You can also do paravertebral blocks bilaterally, but of course you have to be cognizant of the total amount of local anesthetic being used. Ultrasound-guided paravertebral blocks can be done a number of different ways. The patients can be sitting, prone, or lateral, and the ultrasound probe can be oriented in a paramedian or a parasagittal approach versus a transverse approach. With the paramedian approach, you want to have the probe vertically about 2 to 2.5 centimeters lateral to the spinous processes of the back. At that point, the transverse processes can be visualized as these boxy hyperechoic structures with shadowing underneath. And the superior costal transverse ligament that you want to pierce with the needle tip can be seen as these diagonal hyperechoic lines between adjacent transverse processes. Underneath that, a second hyperechoic line can be seen, which is the pleura. With the transverse approach, your probe will be oriented perpendicular to the vertebral column. And you want to have it medial enough to visualize the transverse process in the bottom corner of the screen. And the hyperechoic line or arc that can be seen emanating from that is the pleura and this elongated view, giving you a better visualization of the trajectory of the needle coming in. And the superior costal transverse ligament or the internal intercostal membrane at that point can be seen as a shorter hyperechoic line connecting the transverse process and the pleura. And you want to get the needle tip below that for injection of local anesthetic. If your needle is in the right place, doesn't matter which view, you will see a downward or anterior displacement of the hyperechoic pleural line with local injection. Here's another depiction of the transverse versus paramedian approach for paravertebral blocks and their associated ultrasound images. Again, with the injection of local anesthetic, which is depicted in blue in these pictures, you should see a downward or anterior displacement of the hyperechoic pleura underneath. There are proponents for both approaches. Some say the paramedian approach may be technically more challenging due to the steep trajectory of the needle needed to come in and pierce the superior costal transverse ligament, thus more likelihood for inadvertent pleural puncture due to the difficulty in visualizing the tip of the needle. And with the transverse approach, some say it may be associated with a higher incidence of inadvertent epidural spread due to the needle coming in from lateral to medial and being in a line with the neural foramen. Complications can arise from paravertebral blocks from inadvertent epidural or intravascular injection or pleural puncture. So it's very important to always know where your needle tip location is on ultrasound, as well as always aspirate for air, blood, or CSF prior to local anesthetic injection. So as we follow those spinal nerves out of the back and we move to the mid-axillary line, now we're going to talk about serratus anterior plane blocks. Serratus anterior plane blocks provides anesthesia and analgesia to the anterolateral hemithorax as well as axilla. As you can see in the diagram here, as the intercostal nerves course along the rib, it pierces the intercostal muscles as well as serratus anterior and sends out these lateral cutaneous branches at about the mid-axillary line. Indications for its use are pain from rib fractures, thoracic cases, breast surgeries, including axillary surgeries, and minimally invasive cardiac surgeries or implantable devices. Targets for the block are these lateral cutaneous branches of T2 through T9. The main landmarks you want to be able to spot on ultrasound imaging for the serratus anterior plane block are the ribs, latissimus dorsi, and serratus anterior muscles. Between these two muscles at the axillary fossa lie our target nerves, which are the lateral cutaneous branches of T2 through T9. Along that same plane, you can also find the long thoracic nerve, which innervates the serratus anterior, the intercostal brachial nerve, which is a cutaneous sensory nerve, as well as the thoracodorsal nerve, which innervates the latissimus dorsi. There are two approaches to this block. You can inject either superficial or deep to the serratus anterior, and both approaches achieve similar efficacy with their own pros and cons. The superficial approach is technically very easy. You just find the plane between and inject between the latissimus dorsi and serratus anterior muscle where those nerves lie. But your patient will have a temporary winged scapula from blockade of the long thoracic nerve. You'll have to take care to avoid the thoracodorsal artery, which also runs along that plane, so as to avoid an inadvertent intravascular injection. Some say that going deep may be technically more challenging, but you may be able to avoid a winged scapula in your patient. Here's a diagram showing you probe placement for the serratus anterior plane block in the axillary fossa. On this ultrasound image, the probe was actually parallel with the rib, which is seen as an elongated hyperechoic line towards the bottom of the image. And below that, you can see the dotted white line, which represents the pleura underneath. This was a deep approach, which shows you injection of local anesthetic between the serratus anterior muscle and the rib, thus lifting it up off of the rib. If you initially don't see a latissimus dorsi muscle on your image, you want to move the probe posteriorly until it comes into view. Here's another depiction of the serratus anterior plain block being done with the patient on their side. This was a superficial approach where you can see the local anesthetic being injected above the serratus anterior muscle. This is a high volume block where you want to use 20 to 40 cc's of local anesthetic. 20 cc's will achieve blockade of 4 intercostal levels, and up to 40 will give you 7. So how does the serratus anterior plain block provide effective analgesia for rib fractures when it only targets the lateral cutaneous branches of the intercostal nerves? As can be seen in this great cadaveric study, in an unfractured hemithorax, the local anesthetic injectate is only limited to the superficial planes above and below the serratus anterior muscle without deeper penetration. But if there is a disruption of tissue planes from trauma such as rib fractures, that actually facilitates the spread of local anesthetic deeper down to the intercostal nerves, thus providing effective analgesia, as can be seen in the green staining here over the ribs in the picture on the left.